Hi, everybody. Welcome to the respiratory system. This is our new unit. So today we're going to be talking about air. So the respiratory system is going to be of multi-celled animals, and it requires large surface areas of respiratory organs to be compressed in small spaces in order to meet our oxygen and carbon dioxide exchange requirements of specifically aerobic metabolism. So hopefully you guys remember back, oxygen and carbon dioxide are the two gases that are exchanged super commonly throughout our respiratory system. Obviously, we want oxygen to go in and then obviously go to the cells where we're going to have it help us with aerobic metabolism, which is basically the process of making energy. And as you're making energy, one of those byproducts is CO2. So CO2 builds up as a byproduct in your body at the cells and the tissues, and then it's going to be released out of your body through exhalation. So one of the biggest challenges of these systems is to prevent dehydration. So to prevent dehydration, the exchange surfaces. So exchange surfaces are going to be those surfaces that the oxygen and carbon dioxide go through. So the exchange surfaces must be thin and moist. So thin is going to tell you what type of respiratory surface it's going to be, specifically epithelium, which is going to be simple. And then moist, meaning that it has to have water molecules there so that the respiratory epithelium or the simple epithelium, specifically simple squamous epithelium, doesn't dry out, because when it does dry out, it will crack and eventually lose its function. So you need it to be, again, thin and moist, which allows the gas to pass from air into the solution. And at the same time, it's going to be protected from drying out when it's exposed to the air. So humans are going to prevent dehydration by internalizing the respiratory epithelium in the thoracic cavity and creating a humid internal environment for the area of gas exchange. So internalization creates one more problem. So how do you get air to move between the atmosphere and the lungs? So up here you've got the exchange environment 1, then you've got 2 and 3. So exchange environment 1 is going to be air coming in from the outside air, which is the atmosphere, into the lungs. Exchange site 2 is going to be moving the air from the lungs into the blood. And then exchange site 3 is going to be taking the air and putting it from the blood into the cells. So again, backtrack. How do you um, in talking about internalization, how do you get the air to move all the way from the outside environment into the body? So the way that your body does that is using a muscular pump. The muscular pump is going to use pressure gradients. I'm trying to find, we don't have pressure gradients just yet. But pressure gradients are always going to be like when you talk about like simple diffusion, they're always going to go from areas of high concentration to low concentration. So for example, you guys can see oxygen is going into the body, which means that the highest concentration of oxygen is outside of the body. And then let's just kind of use an example here. These are not accurate numbers at all. I'm just throwing any number out there at all to help you guys try to understand what it is. So let's just say the concentration of oxygen is 100 outside, then inside the lungs, let's say it's something like 80. So you guys can see now that the pressure difference is going to push the oxygen into the lungs from the outside environment. Then going from the lungs into the blood, maybe it's 80 to 60. Same idea, you're still going to push the oxygen into the blood. And then going from blood to capillaries, maybe it's 60 to 40. And you're going to push all of that oxygen that was on the outside of the body all the way into the cells at the tissues, so that now you can use it for cellular respiration. Now, the opposite is true of the concentration gradient for carbon dioxide. Let's say carbon dioxide is going to, and it does, right? It's moving out. So its highest area of concentration is going to be on the inside of the cells. And then you'll move lower and lower until you get to the point where it's in the air, and let's say it's like, I don't know, 20 here. But the idea is still the same, is it's always going to move down its concentration gradient the concentration gradients for CO2 and O2 are always going to be opposites. Okay, let's move. So there are 4 primary functions of your respiratory system. This is important. First function is obviously exchange of gases between the atmosphere and the blood. So atmosphere and blood. There's several meanings to the word respiration in physiology. We're going to focus on a few of their specific definitions or processes. First one is going to be ventilation. So here's the definitions, right? Ventilation or breathing is going to be the mechanics of inspiration or inhalation and expiration or exhalation so that the atmospheric air enters and exits the alveoli. External respiration is going to be the exchange of gases between the alveoli and the pulmonary capillaries. Gas transport is going to be the movement of oxygen and carbon dioxide by the blood. Doesn't matter which way it's going, whether it's in or out, it's just transport of a gas by the blood. Internal respiration is the exchange of gases between the systemic capillaries and the cells or tissues. And then cellular respiration is the internal utilization. So basically inside your body, utilization of oxygen to create, so ATP obviously is the biggest one there, but then it also generates carbon dioxide and water as byproducts. So carbon dioxide is an important byproduct because you need to get rid of it. Otherwise it becomes toxic in your body. And then water is an important byproduct because the majority of your body is made up of water. So when you undergo cellular respiration, your body's going to use ATP for lots of different things, right? For energy. You're going to get rid of the CO2 and then you're going to move the water to wherever it is that you need it in your body. Second primary function is homeostatic regulation of pH. So pH, okay. pH is altered by either hypo or hyperventilation, which changes the carbon dioxide levels in your body. Third is going to be protection from inhaled pathogens and irritating substances. So the reason why your respiratory system uses or how it plays into this is that you are, hopefully if you guys remember back to 60 or 21A, you had, when you talked about the tissues, your respiratory tract, specifically your trachea, is going to be lined with pseudostratified ciliated columnar epithelia. That PCCE tissue, it produces a mucus, and then the mucus will trap a pathogen. So if you inhale something like dust or dirt or debris, or I mean, hopefully not, but like a bug, the mucus in your trachea should trap that pathogen, move it back up what we call the mucociliary escalator, and then it's going to be ready to be coughed, spit, or sneezed out of your body. So again, third function of your respiratory system is for protection of inhaled pathogens and irritating substances. It's a defense mechanism trap, and it's to destroy potentially harmful substances. So your body doesn't really know that dirt isn't going to kill you. Your body just recognizes dirt as foreign. So the dirt will be trapped and then hopefully be gotten rid of out of your body. And then the last function is vocalization, so talking, which is the air moving across your vocal cords, which creates vibrations for speech, singing, and other forms of communication. The respiratory system has what we would call bulk flow of air through it, and that's going to follow the same principles that we talked about in the blood system. Okay, I am going to jump back to this in just 1 second. I'm going to go through a tiny bit of the anatomy on this real quick because it's an AMP class and we do need to talk about the anatomy a little bit while we're here. So it's not going to let me zoom, but your first image here is going to be muscles. The muscles are important because when you're breathing, while you can breathe passively, you can also use what we call forced inhalation and exhalation and use basically secondary muscles. This is all what you would call like quiet breathing or involuntary breathing. And on the left here, it's going to show you the sternocleidomastoid, the scalenes, external intercostals, and the diaphragm, which are for inhalation. And then for exhalation, you're going to use the internal intercostals, which makes sense, right? The antagonistic muscles. and then your rectus abdominis and your obliques for expiration or exhalation. When you break your respiratory system into different systems, anatomically speaking, you have this, theoretical line that runs kind of right through the larynx, and it's going to divide the upper and the lower respiratory systems. So if, for example, you have like a sinus infection in your nose, a doctor might say you have an upper respiratory tract infection, which basically just tells you the location of your infection. So your upper respiratory system is going to include the nasal cavity, the tongue, the pharynx, vocal cords, and then part of the larynx. Your esophagus isn't so much important for your respiratory system unless obviously something goes wrong when you're eating or digesting food and you forget to, let's say, move the epiglottis over the trachea, and eventually what would happen is when you're swallowing food, you basically choke on it, because instead of having the food go down your esophagus, it goes down your trachea or your windpipe, which causes you to choke. Other than that, the esophagus isn't super important for respiratory. Then that drops you into your lower respiratory system, and you have the trachea. The trachea then is going to bifurcate or split into bronchi. Now it's here where we're at, right? So you have the larynx, the trachea, and then you split into the left and right bronchi. So you'll go, just depending upon how many branches you have. The first branch is called the primary bronchus. Second branch is secondary bronchus. Third is going to be tertiary. Then you divide into bronchioles. Difference anatomically between tertiary and bronchioles are that the bronchioles have no cartilage. And then lastly, you terminate in these alveoli, or these little grape-like structures. These grape-like structures are super important. This is the site of gas exchange. So we'll go into a lot of detail here, but you guys can see that when you take a cross-section here of the alveoli, you have simple squamous epithelia, which is important because it's really easy for gases to move through thin and one-layered tissue and then move from one side to the other. Here is a sectional view of your chest. So basically you have the left and the right lung here with the heart here. This is posterior, this is anterior. And then here you have the different lungs. I don't know if you guys realize this just yet, anatomically speaking, but your lungs are not the same in size. So if you guys kind of see this notch right there, that notch is really important because what sits there is your heart. So your right lung is bigger than your left lung, and because of that, it has 3 lobes. Right lung has a superior, middle, and inferior lobe. The left lung just has a superior and an inferior. Because it has 3 different lobes, it has 2 different splits. It has a transverse and then an oblique, whereas this one just has the oblique. And then that notch is literally called a cardiac notch. So basically just the notch for the heart. Okay, so now that we're done with the basics on the anatomy, let's continue on. Actually, this is a really good picture. Let me just briefly stop here again. The splits, so you got primary, secondary, tertiary, bronchioles. Now you can see that the blue, which was cartilage, is now gone in the bronchioles, and then the alveoli are going to be the termination of the airways. Okay, so let me jump back real quick and talk about bulk flow. So no great image for this because we just finished this in blood, but basically those same principles that we talked about for blood flow in the cardiovascular system are going to be the same principles that govern air flow through your respiratory system. So one is air flow occurs from high pressure to low pressure, like we talked about just a minute ago. 2 is a muscular pump will create the pressure gradients. So you don't have to worry about your body working on those gradients. The muscular pump, which is smooth muscle, will do that completely for you. And then 3, resistance to airflow is influenced primarily by the change in diameter of the tubes through which the air is flowing. So again, that goes back to the same thing we talked about with our cardiovascular system. The main factor that's going to change the flow is going to be the radius, right? It's the diameters or radius, they correlate to each other, obviously, of how big the tube is. The main difference between air and blood is that air is much less viscous, so it's not as thick, and it's compressible, whereas blood is not. Okay, that takes us into breathing. Okay, so this guy is, let's say, I don't know, in New York or Boston or somewhere back east, and we'll call it winter, and he is running. I don't know if you guys have ever run in cold weather or colder weather than you're used to, but if you do, you'll know that it can physically hurt your chest. So during breathing, here's what happens. The upper airway and bronchi are not just passageways for air to flow. They also play a really important role in what we call conditioning the air before it reaches the alveoli. So, conditioning the air includes three different things. Number one is warming the air. Number two is humidifying the air. And number three is filtering the air. I cannot tell you how important this concept is for you guys. So, make sure you know these three parts to the conditioning, what they each do, what different types of tissues are involved in the different components to conditioning, all of it. All of this is very important. So here's where we're going to tie the conditioning into this guy running. If this runner does not condition the air appropriately before it gets all the way to the site of gas exchange, the alveoli, what can happen is you can actually damage the tissue, which will physically hurt your chest. So again, warming the air means bringing the air up in temperature or down in temperature, most commonly up though, to 37 degrees Celsius, so that it's your normal body temperature. The idea here is you don't want super, super, super cold air or super, super warm air coming into your body and all the way at the alveoli with a very drastic change in temperature, because the change in temperature will damage the alveoli. Again, that's not great, because the alveoli are super important for the site of gas exchange. So you have blood vessels that travel through the body's mucosal lining that's going to help transfer heat to the inhaled air, so that it's typically about 37 degrees Celsius before it reaches the trachea, right? The trachea is that first branch. Breathing through your nose is more effective than breathing through your mouth. And here's where our runner comes into place. Because most of the time when you're running, it means, or exercising, cardio, whatever it is that you want to do, you're not breathing through your nose. So it's much more important that the amount of oxygen that comes into his body or her body is higher than it is important that it's conditioned properly. So this guy would rather have enough oxygen rather than conditioned air in coming all the way down to his alveoli. So instead of breathing through his nose, because literally the diameter of the nostrils is much smaller than the mouth, he's going to be breathing through his mouth. Now, when you breathe through your mouth, you lose some of these conditioning abilities, right? You're not going to have all the same structures, like nose hairs are really important for filtering, right? You're not going to have nose hairs in your mouth. So what happens is you lose the ability to condition the air when you breathe through your mouth, which is why I just stated it's more important, or sorry, it's more beneficial for you to breathe through your nose. It's more effective. However, when you're exercising, it's more beneficial for you to breathe through your mouth, just because the sheer amount of oxygen that you're going to need is much higher. Okay, conditioning number two is humidification. So you're going to want to bring the air to 100% humidity so that the exchange epithelia, right, that simple squamous epithelia, doesn't dry out. Again, the water, okay, so how do you humidify? Water is going to evaporate from the mucosal lining of the airways to help provide the humidity. If that didn't happen properly, or you were, let's say, breathing through your mouth a lot more commonly, what would happen is the air gets to the respiratory exchange epithelia or your simple squamous epithelia. It's very dry, and it will eventually have a damaging effect on the simple squamous epithelia, which will cause it to lose its function, which means now all of a sudden that area of gas exchange, the effectivity has drastically decreased. And then the third thing is filtering. So your respiratory system will help filter out foreign material. That's going to be cleaning the air of viruses, bacteria, fungi, and then also organic or inorganic particles. The idea there is that you keep all of these pathogens from reaching the alveoli. The airway is going to be lined again with PCCE, right? It's the pseudostratified ciliated columnar epithelia, and that is the epithelia that's going to filter the incoming air. So how that happens is this is the PCCE. These are goblet cells inside of there. The goblet cells are going to secrete the mucus, and the mucus is going to lie on the apical side of the tissue. Then the dust particles or dirt or pathogen or fungus, whatever it is, can get stuck inside the mucus. And then what happens is, because cilia help with movement, the cilia are going to move the mucus up the mucociliary escalator, which basically just means superiorly, and it's going to give the individual the ability to cough, sneeze, or spit this mucus out, which had the pathogen inside of it. Okay. So the epithelial cells are going to use what we call a CFTR, or it's a cystic fibrosis transmembrane regulator. So it uses these specific channels, and it uses them to help with saline secretion and goblet cells in the epithelium, to help secrete mucus. And then again, the mucus will trap the pathogen and the particle, cilia move it up, and then it's ready to be released. So really how this works, it's a very simple pathway. Number one, it's an NKCC. So it's this sodium and potassium and chloride exchange, and it's going to bring chloride into the epithelia from the ECF. ECF is on the bottom side here. Number two is you're going to have an apical, just means the free side of the tissue. So it's going to be an apical anion channel that includes the CFTR channel right here. This is the CFTR, and it allows the chloride to enter into the lumen. From there, you're going to go down to step 3, and sodium is going to go from the ECF to the lumen through these paracellular pathways. So para means between the cells. But so it's going to go through the paracellular pathways, and they're going to be drawn through an electrochemical gradient because the chloride has already moved. And then the last step is, I think maybe at some point you should have heard this, solutes suck. Solute is the sodium, and it's going to suck. What it sucks is water. So sodium goes first, and then basically the water follows into the lumen. So this is one model of saline secretion for your airways and the epithelial cells. Your clinical on this is cystic fibrosis. So this little boy has CF. It is an inherited defect in the CFTR channel that's going to lead to a decreased fluid movement in the airway. So let's jump back. This channel is not working properly, which means the fluid isn't going properly either. So without the proper saline layer, mucus cannot be cleared. Mucus can't be cleared, bacteria are going to colonize. If they colonize in the airways, you're going to have a very good chance of having common lung infections, and that's cystic fibrosis. Okay, the pulmonary circuit. So review of the alveoli right there, the site of gas exchange. Your pulmonary circulation is high flow and low pressure. So your pulmonary circuit, if you guys remember, it blood flow, right? So you go right atrium, right ventricle, and then you go out the pulmonary trunk. The pulmonary trunk is going to split, and it's going to take you right and left. Excuse me, right and left into the lungs. The idea there is that the blood is now able in the lungs to pick up oxygen. So low oxygenated blood is pumped from the right ventricle, into the pulmonary trunk right here, the pulmonary trunk, and then into the pulmonary arteries. So you have the left pulmonary artery carrying the blood to the left lung, and then the right pulmonary artery carrying the blood to the right lung. So the blood will pick up the oxygen, and then oxygenated blood is going to return to the heart. So it's going to return through the pulmonary veins, right and left respectively, and dump in the left atria. And from there, the rate of blood flow through the lungs is much higher than the rate of other tissues, because lungs receive the entire cardiac output from the right ventricle, which is about 5 liters per minute. This is the same as what would go to the entire rest of the body. So it's very, very, very high flow, low pressure. So although the rate is high, your pulmonary blood pressure is low. It's something about like 25/8 compared to that of your entire systemic circulation, which should be 120/80 if you're healthy. Normally, your right ventricle does not have to pump forcefully to create blood flow through the lungs because there's low resistance. So, low resistance means it doesn't have to work that hard. The low resistance is created by the fact that they've got short vessel lengths, right? They don't go very far. They're very distensible arterioles, meaning they can expand very well. And then the large cross sectional area of the arterioles can all contribute to the fact that they have very, very, very low resistance. Okay, moving into gas laws. So, gas laws, your respiratory system is governed by gas laws that affect the air that is exchanged between the atmosphere and the body. Air pressure can be expressed in what we would call the units, millimeters of mercury, nothing new there, just like blood pressure. So, at sea level, your atmospheric pressure is going to be 760 millimeters of mercury. But oftentimes your book will kind of just designate atmospheric pressure at 0, which will allow you to make much easier comparisons without correcting for the altitude. So, a couple of gas laws that we're going to talk about. The first one is going to be the ideal gas law or the ideal gas equation. And this is your standard PV equals nRT. So, PV equals nRT is going to help summarize the relationship between the pressure, or P, volume, V, temperature, T, and then the number of moles, which is N. So R is a universal constant. It is going to be 8.3145, as you guys can see here. Assuming the moles and the temperature are constant, because moles will be, temperature should be, or your body temperature should be normal body temperature. Yes, it will fluctuate, a degree here or there, but it's not going to change significantly enough for it to be a variable. So assuming the moles and the temperature are constants in the body, all we have left is the relationship between pressure and volume. So if they're on the same side of the equation, to move them on opposite sides of the equation, you would need to divide by, let's say, P. So you divide by P, cancel it out, and this is left to be a 1 because those are constants. So it'd be 1 over P. So that really leaves you with this relationship. Volume equals 1 over P, which tells you that if the volume of gas increases, the pressure of it is going to decrease. So they're inversely proportional. So this is what we would call Boyle's law. Boyle's law is pressure and volume. So Boyle's law helps express the inverse relationship between the pressure and the volume in different containers. So P1 V1 equals P2 V2. So this law states that if the volume is reduced, the pressure will increase. This occurs because the pressure of the gas is created by the collisions of the gas molecules inside of the container with other gas molecules. So as you guys can see here, basically the more space you have, the less collisions you have. The less space you have, the more collisions you have. That's why they're inversely proportional. So again, collisions are more frequent when the volume is smaller and smaller and smaller, which means pressure increases. Your respiratory system, where does this correlate to? Okay, so your respiratory system, what changes pressure and volume constantly is your thoracic cavity and then your lungs. So your thoracic cavity, you guys, one of the coolest things about the respiratory system, and one of the things that I feel like makes it so easy, is that if you're trying to figure this out, you can literally all breathe in and breathe out and figure out what is going on anatomically and then correlate that to the physiology of it. So if you guys all take a really big breath in, and you'll notice like what happened to the volume of your thoracic cavity. Well, you guys noticed that your thoracic cavity volume increased. When the volume increased, that means the pressure decreased, right? You're moving this way. So that is going to be Boyle's law. So your thoracic volume pressure gradients are going to change when you inhale and exhale, which is going to change the way that your gases are moving. So the last equation that we'll talk about is air when it's in a mixture of gases, and that's going to be Dalton's law right here. Oh, I'm sorry. I completely skipped through. These were bigger pictures. Okay, so here's your most basic atmospheric pressure. This is how we describe atmospheric pressure in the very beginning. right? It has to do with the millimeters of mercury that goes through the tube, but again, we just kind of set it at 0. This is the ideal gas law, Boyle's law, and here we are with Dalton's law. So Dalton's law is going to say the atmosphere is a mixture of gases and water vapor. So it states the total pressure exerted by a mixture of gases is the sum of the pressures exerted by the individual gases. So the pressure of the individual gas in a mixture is going to be the partial pressure of that gas. So for example, right, atmospheric gases, you don't just have one type of gas in there, right? You've got oxygen, carbon dioxide, and water vapor in this particular mixture. So for example, in dry air, so we're right here in this first column, in dry air, um, a total pressure of 760 millimeters of mercury of, so PO2 means the partial pressure of O2 is something like 160 millimeters of mercury. They got that calculation by just going through and calculating the partial pressure times the, so you're looking at different total pressures as well. So partial pressure of oxygen is about 160, partial pressure of carbon dioxide is about 0.25, and then the partial pressure of water vapor is 0. Now, also, they left out here, but you would have a partial pressure of a nitrogenous gas, or N2, which would be about 600. So the partial pressure of gases will decline in humid air as the water vapor is going to dilute it. So if you guys notice dry air, there's no water vapor. But all the way over here at 100% humidity, you've got a lot of water vapor, and now you've got more dilute partial pressures because the water vapor is diluting it just like anything else would. Right? Water is always going to dilute. Okay. Here is the same kind of example with inspired air versus alveolar air. So this is breathing in, the variables here, or sorry, the different types of gases here, and then the total pressures. So inspired air, water is variable, obviously depending upon the environment that you're in. In California, it's very dry, but in, let's say, North Carolina or Texas or some of the southern states, super, super, super humid. So variable just means that we don't know what environment you're in. CO2, O2, N2, and then total pressure. So this is air going in the alveoli. Now the air in terms of water is going to be 47, CO2 is 40, O2 is 105, and then N2 is 568. Still gives you the same total partial pressure. Okay, so gases move down pressure gradients. Again, that's something that hopefully you guys can get to stick in your head because that's one of the most important and common concepts. So knowing the partial pressures of the individual gases will allow you to know which direction the gas is going to flow. Diffusion of gases, again, always occurred down the partial pressure gradient from high to low, but there are changes in partial pressure of the gases. So changes of those is one of the most important variables that affects the movement of the gas. So if you take a second and look at this table on altitude changes, it is going to affect the partial pressures in the air, and it's going to change the way that your body is either going to intake or put out different gases. So if you guys notice, basically sea level, right, the partial pressure of oxygen in the air is 160, whereas the partial pressure of oxygen in your blood is 100. So you're obviously going to go very easily from the air into the blood. But as you go higher and higher in altitude, let's stop here somewhere around 10,000. So 10,000 feet is, look at the partial pressure. It's about 109 and 69. Now you're starting to close the gap. Let's go to all the way to the bottom at 30,000. So 30,000 feet is, the tallest mountain in the world is 29,000. It's Nepal and Tibet. So Mount Everest. So partial pressure of air is 47. Partial pressure of oxygen in the blood is 19. You guys will start to notice that at some point, what's going to happen is the partial pressure is basically going to switch, and the gradient will go from inside, so outside to inside, to switching, going from inside of your body to outside. So again, depending upon the altitude that you're at, oxygen is either going to be going into your body or out of your body. So, obviously, the danger in going to places like Mount Everest and hiking, which is very physical, obviously, is that your body really, 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 really needs to be conditioned in order to account for the lack of oxygen in the air, which means it's going to be much more difficult to put the oxygen into your body, which means that your body's going to have a really hard time making energy. One of the cool things to talk about for this is, I mean, I'm sure you guys know, but for the the Olympics, oh, we still haven't had them. So for the Olympics, right, our athletes for the United States don't yes, we have really good athletes in California in general and all over the United States, but we don't have our professional athletes train in the areas where they live necessarily. Most of our athletes are going to go to the mountains of Colorado and they're going to train there because altitude is high. What happens physiologically when you go to higher altitude is your body has to adjust. So let's say you're a Olympic sprinter and you want to be performing at your best in the Olympics. You're going to go train in the mountains of Colorado for a set amount of time where it's more difficult to breathe. So let's 1500 feet, somewhere right in between here. Let's call it, I don't know, 85 to 90. Partial pressure of oxygen in the air is 85 to 90. Partial pressure of your blood is, I don't know, let's call it 45 or 50. You're closing the gap on the difference between the partial pressure and the air and of your blood for oxygen, which means that this particular individual, their body physiologically is going to want to change something to help offset the lack of oxygen. So one of the most common things this your Olympic athlete body is going to do is you're going to create more red blood cells because your body has no idea that you just changed the environment physically and you went to an area with less oxygen in the air. Your body's going to perceive that as maybe I'm just not carrying enough oxygen. So how do I do that better? Well, let me go make some more red blood cells. When I make some more red blood cells, then I can have more hemoglobin. When I have more hemoglobin, then I have more iron. When I have more iron, now I can carry more oxygen. So that's one of the first things. Another thing that's going to happen is that your respiratory muscles are going to increase in their effectiveness because they need to work more often, right? If you're getting less oxygen in with every breath, you're going to have to breathe more often, which means your respiratory muscles become more effective or stronger. Another thing that happens is your blood is going to circulate faster because maybe it's not a red blood cell problem anymore. Maybe it's just that your blood isn't getting to the tissues well enough to drop off the oxygen. So you increase your circulation, you increase your red blood cell count, and then you increase your muscular tone for um, your respiratory muscles. All of those are going to make you a better athlete. So when all of those make you a better athlete, you're hopefully going to perform better in your Olympic maybe trials or in the actual Olympics. So there's a very, very, very good advantage to training in higher altitude environments. For normal people that maybe just want to go do something crazy and want like, a couch potato or maybe even I don't know, a 5K runner who's like, I want to go to Mount Everest and go hike the tallest mountain in the world. You're not going to want to do it without a lot of training physically for your body and then also in high altitude areas to try to get your body to um, offset the increase or the decrease, sorry, in oxygen in the air. Otherwise, it can become fatal. There are lots of things that can happen because the altitude change so quick, so fast. Okay, so moving on to gas solubility. So your gas solubility is going to affect your diffusion. So another factor that affects gas exchange in the alveoli is the solubility of your gas. So the movement of the gas molecules from air into liquid is directly proportional to three factors. One is the pressure gradient of the gas. 2 is going to be the solubility of the gas in a liquid. And then 3 is going to be the temperature. So when a gas gets placed in contact with water, there is a pressure gradient. Gas molecules will move from one phase to another. So for example, water exposed to air with the partial pressure, we're right here. Water exposed to air with the partial pressure of 100, whereas the water has a partial pressure of 0, right? So no oxygen here. What's going to happen is the oxygen is going to dissolve. So if the air stays in constant contact with the water, some of the oxygen will move from the air, as you guys can see here, into the water. This will continue until an equilibrium has been reached. The equilibrium is going to be the partial pressure in the air and the water. However, here's where you guys see a difference, right? They don't have to be an exact equal ratio. So the difference in the concentration is going to be due to their solubility. So while these two environments here and here are in equilibrium, it's equilibrium, but the concentration is different, right? Concentration up here is 5.2, concentration down here is 0.15. The difference again is the solubility of the air versus the water. So your solubility affects the concentration of dissolved gases in the water. The ease at which the gas dissolves in the liquid is the gas's solubility. So carbon dioxide is going to be the most soluble. Oxygen then comes next. Then nitrogen is going to be the least soluble at sea level. So carbon dioxide is approximately 20 times more soluble than oxygen, which is why oxygen requires a carrying molecule in your blood plasma. Carrying molecule, you guys know, is hemoglobin with an iron ion, excuse me. Physiologically, it's important to think about the solubility. So for example, because oxygen has a low solubility, it is slow to diffuse across the liquid. Because of that, um, when patients suffer from pulmonary edema, their alveolar partial pressure of oxygen may be normal and their arterial will be decreased. So we have this law. So we're American. You probably pronounce that Henry, but this guy's actually not American. It's pronounced Ennui. You guys can pronounce it however you want to. His actual name is Ennui, so it's Ennui's law or Henry's law, whatever you want to say. But his law states that the solubility of the gas in a liquid is directly proportional to the partial pressure of the gas above the liquid. So his equation is P equals HV times M. P is your partial pressure. HV is going to be Henry's law constant. And then M is the molar concentration of the gas solution. So constant is 769.23 for oxygen and then 29.14 for CO2. So that brings us all the way down to our scuba diving example for both Dalton and Henry's law. So in inert gas like nitrogen, which is also abundant in the atmosphere, when it enters and leaves the respiratory system without chemically reacting to other molecules, but it is soluble in the blood. So if it were in its gaseous form, it would pose a really big physical problem in the form of air bubbles. So air bubbles are a really big deal. So the partial pressure of nitrogen, according to Dalton's law, is high in the atmosphere and the alveoli, but because of its low solubility, there's also little nitrogen in the blood at sea level. However, this is a scuba diver. So in scuba diving, you know that altitude decreased. In scuba diving, there is an increased solubility of nitrogen as the diver is going to descend, go down. So for about every 10 meters of depth of the pressure is going to increase by 1 atmosphere or 760 millimeters of mercury. So as the scuba diver goes further and further down, the pressure of air they breathe is actually going to match the pressure of the water around them. This increases the partial pressure of nitrogen, increases the solubility in the blood, which is going to be described as Henry's law. So the increased solubility is caused by the increased compression. So if this diver ascends going back up too quickly, and nitrogen bubbles start to develop in this person's blood, the diver will suffer from what we call decompression sickness or the bends. So that process would be as followed. Um, Number one, the scuba diver breathes in a mixture of gases during their descent or going down, including nitrogen. Some of the gas mixtures use helium instead, but helium can also cause DCS or decompression sickness. So as the diver descends, the partial pressure of nitrogen increases. Nitrogen becomes more soluble in the blood. Number three, the amount of gas dissolving in the blood is proportional to the partial pressure of gas and is described as both Henry and Dalton's law. Number four, as the diver goes back up, the inert gases off gas or out gas, either one, same thing, through normal gas exchange in the lungs as partial pressure of gas is going to decrease as well as the solubility. So the ascent rate to prevent DCS is you can go up 10 meters per minute with a scheduled predetermined decompression stop. So number 6, if the ascent or going back up is too quick, improper decompression will occur, which leads to nitrogen gas bubbles forming in the circulatory system or in the blood and in other tissues of the body. That will cause, number 7, this is DCS, and it's most frequently causes joint pains, can lead to neurological symptoms, um, um, so seizures, paralysis, and even pulmonary symptoms such as shortness of breath. So how do you treat this? So number 8, treatment of this DCS is in what we call a hyperbaric oxygen therapy machine. It is a recompression chamber. So basically the individual gets inside this chamber and somebody on the outside is going to manually control with their gauges the amounts of oxygen and nitrogen and CO2 in the air inside the chamber. So DCS can also be caused by leaving a high pressure environment or ascent to high altitude. Again, it's a high pressure to low pressure environment, so that's where all of this really comes into play. So hopefully everything is done properly so you can avoid the hyperbaric chamber. Okay, getting into the physiology in a more practical environment for you guys. Ventilation. Again, definition of ventilation is a respiratory cycle, consists of inspiration followed by expiration, and involves the change in lung volumes and capacities. So, how much you can take in or out. So, ventilation, breathing is an active process. It requires muscle contraction as well as the use of energy, obviously. Contraction of the thoracic musculature, abdominal musculature, and the diaphragm are all going to change the lung volumes, right? The lung volumes would increase, and therefore the pressure, which would decrease when you breathe in. The primary muscle for normal breathing is going to be the diaphragm. So in this picture, the diaphragm is that little curved line right there. So airflow follows what we call Poiseuille's law. Poiseuille's law, which we've also talked about this before with blood pressure. So this was blood flow before, but now blood flow is going to equal airflow. So blood flow or airflow equals the change in pressure times the pi times radius over 8L, which is length, and then this is the Greek letter eta. Eta is viscosity. So inspiration, here we go. Inspiration. Inspiration occurs when alveolar pressure decreases. So for air to enter into the alveoli, the pressure in the lungs must be less than atmospheric pressure. So again, you want the air to go in, right? High concentration to low concentration. So Boyle's law states that if the volume increases, the pressure will decrease. So how do we decrease the volume? If you contract the diaphragm, so you're going to contract the diaphragm and basically straighten it out. And then also have the external intercostals pull the rib cages up and out. You're going to increase the environment or the volume of your thoracic cavity. When you increase the volume, you decrease the pressure. So again, Diaphragm is going to contract, external intercostals and the scalenes are going to help pulling the ribs up and out. So during inspiration, the alveolar pressure drops below atmospheric and the interpleural pressure stays below alveolar. So it should look like this. Oh, these are the muscles, sorry. Again, sternocleidomastoids, scalenes, external intercostals, obviously as well as the diaphragm. So in inspiration, again, the dotted lines is where they normally sit. The lines where they're at is with the breathing in. So you guys will notice, again, the thoracic volume has increased. With expiration, it's the opposite. So you'll have elastic recoil of the lungs, and then the thoracic cage is going to return the diaphragm and the rib cage to their original positions, which decreases the thoracic cavity volume, which increases the pressure, which means now the air is going to be moving out of the lungs. This is a passive process. So normal expiration is called passive expiration because it doesn't require muscle contraction. It's just the relaxation of the muscles. During expiration, the alveolar pressure increases above atmospheric and the intrapleural pressure increases, but it remains below alveolar and atmospheric. But it does have the ability to undergo forced exhalations, or what we would call active expiration, which uses the internal intercostals and the abdominal muscles to decrease the thoracic cavity volume, and which would increase the pressure for exercise or blowing up a balloon. Those are the two most common things. Most commonly, we do examples of blowing up a balloon because you can easily see what that looks like in class without having to make you run up and down stairs or anything. Okay, intrapleural pressure is going to change during ventilation. So again, ventilation requires the lungs to expand and contract with the thoracic cavity. The visceral pleura and parietal pleura are going to secrete serous fluids into the pleural sac, and the cohesive forces of the fluid help the lungs adhere to the thoracic cage. So it makes the lungs stick, essentially. The intrapleural pressure of the fluid is going to be subatmospheric or below atmosphere. This is created by the outward pull of the thoracic cage and the inward recoil of the lungs. So during normal inspiration, the intrapleural pressure drops to about -6. So if you guys can see here, you've got columns, which is basically breathe in, breathe out, breathe in, breathe out. And these are all volumes that are taken by what we call a spirometer. So the breathe in, right, during normal inspiration, the intrapleural pressure drops to about -6. During expiration, the intrapleural pressure is going to increase to about -3 millimeters of mercury. So the intrapleural pressure should never equilibrate with atmospheric pressure. That would be very, very, very bad. That would be what we call pneumothorax. So pneumothorax is when you have so again, I don't know that I mentioned this well enough. I know I just said it, but really what happens is you have a seal, right, on the lungs and then the rib cage so that everything is held in that particular area. So when the sealed pleural cavity is opened up to the atmosphere, like in this particular case, when a knife came in, so opened up, this is the sealed cavity. This is obviously the atmosphere. A knife penetrated the lungs and broke open the seal. So when the seal is opened right to the atmosphere, air is going to enter and the fluid, right, because there was fluid that helped hold the lung to the thoracic cage, the fluid bond holding the lungs to the chest wall breaks. If there's no hold or glue anymore, holding the lung to the thoracic cage, it's going to break away. So the chest wall expands, the lungs are going to recoil, resulting in a collapsed lung. Treatment here is going to involve removing the air from the pleural cavity. So any excess air in there you're going to want to remove. And then you're going to need to seal up that hole so that the lung has the ability to re-inflate. Spontaneous pneumothorax is a little bit different. Spontaneous pneumothorax is divided into primary or secondary. So primary occurs when no lung disease is present. Typically, that would be like a congenital bleb, which means the weakened section of lung tissue when it ruptures and it allows alveolar air to escape into the pleural cavity. that would increase the pressure and collapse the lung. Secondary spontaneous pneumothorax occurs when the patient has lung disease. Most commonly, that lung disease is COPD. So here's what this image looks like of a collapsed lung. You guys notice that the lung is sealed perfectly to the thoracic cavity over here. You'll notice that the left side, this is all of the subject, by the way. So notice that the left side, the seal has been broken, the lung has collapsed, which means it's not very effective in bringing oxygen into the body. Oops. Okay. So compliance. Compliance is very important. So lung compliance and elastane may change in a disease state. So compliance is going to be the ability of the lung to stretch. Most of the work of breathing goes into overcoming the resistance of elastic lungs and the thoracic cage to stretching. So compliance refers to how much force has to be exerted to change its structure. It gets expressed in this particular formula as change in volume over change in pressure. So high compliance is when the lung stretches easily. Low compliance is when the lung requires more force and inspiratory muscles to stretch. So typically our lungs have really good compliance, about something like 100 times greater than a balloon would, which, I mean, you guys, I'm sure, have blown up balloons at some point, and balloons are very easy to blow up. So it gives you an idea of how our lungs really work. Elastanes, which is recoil, is going to be the ability to return to the original shape after deforming force is removed. So this elasticity is important with expiration. After the lungs have stretched, they return to their original shape because of the elasticity, which gives them the ability to expel the air from the lungs passively. There's two different types of compliance: obstructive disorder and restrictive disorder. So emphysema is commonly known as COPD. It's when you have elastin fibers in the lungs that are destroyed. So the lungs have high compliance. That would be increased compliance. So COPD would be an example of obstructive disorder. So they have decreased elastanes, which does not allow for expiration, which results in air being trapped inside the lungs. So high compliance and decreased elasticity, air gets trapped in the lungs. That's emphysema or COPD. A restrictive disorder, so like pulmonary fibrosis, which can be a result of scar tissue developed on the lungs due to maybe asbestos or coal. Most of the time, they're occupational hazards. So the restrictive disorder would decrease the compliance and make it very difficult to increase air at all. So it decreases what we call your vital capacity, which is one of the volumes of intake of air. So here's what that kind of looks like, right? Differences here and here. Okay, so we have gotten to the point where we are now ready to talk about the alveoli. So again, the alveoli are going to be the little grape-like structures that is the site of gas exchange. Alveoli are super, super, super important. What would happen if they weren't inflated like those little grape-like structures, or they had, let's say, different amounts of surface tension or different sizes? It'd be really difficult to breathe, and it'd make your work much harder than necessary. So your body produces something called surfactant. Surfactant is a fluid that is going to decrease the work of breathing done by your body. Obviously, that's a great thing because you're breathing all throughout the day. So fluid within the alveoli creates surface tension. Water molecules, right? Water molecules are going to hydrogen bond together to generate tension. The law of Laplace, or Laplace, we'll just call him Laplace, says, here we go. P equals 2T over R. So P is pressure, 2 is a constant, T is surface tension, and then R is going to be the radius. So it states that the pressure inside of the bubble is going to be a result of the surface tension and the radius. So what that says is it's comparing small alveoli. It's going to compare small alveoli to large alveoli of the same tension. The pressure will be greater on the smaller one, which means that you're going to have to work harder to expand the small alveoli. So surfactant gets secreted by what we call type 2 alveolar cells. The surfactant gets secreted and it's going to help reduce the surface tension in the alveoli. It does so, which means that all of a sudden when the surface tension gets released, although the size is different, this is large, this is small, your body still has to do the same amount of work to exchange the oxygen and CO2 between this particular tissue and between this tissue, which is a good thing. You don't want your body to have to overwork to exchange gases. So surfactant is a mixture of proteins and phospholipids that are going to interfere with water's ability to hydrogen bond. So the smaller alveoli have more surfactant than the larger ones do, which means the tension gets reduced to equalize the pressure between the small and the large, so the work to inflate them is going to be equal. Now, something called NRDS is newborn respiratory distress syndrome. So obviously we just said the alveoli are important. Surfactant are important for the alveoli because surfactant's going to reduce the surface tension to help the exchange of gases. But one of the last body systems to develop in utero is the respiratory system. So in utero, the fetus doesn't have fully functional lungs until maybe about 6 months, 5 to 6 months. So what that means is if a baby is born premature, this newborn who is preemie potentially has what we call respiratory distress syndrome. So it's premature babies without adequate surfactant. So their body hasn't developed the type 2 alveolar cells yet in order to produce the surfactant. If the body can't produce the surfactant, the alveoli can't inflate properly, which means they have collapsed lungs. Obviously, you guys, that's really important to fix right away because collapsed lungs means they can't breathe on their own. So there's a couple different types of treatments. One of them is a breathing treatment. It's an aerosol treatment of artificial surfactant. So obviously we've made man-made surfactant to help give to the premature baby until their body has completely developed to use the type 2 alveolar cells to make the surfactant on their own. They can also administer oxygen treatments. They can do artificial ventilation and put them on respirators, or they can also use corticosteroids to give the babies a little bit more of a fighting chance to increase the strength of their body. Sometimes you can do a combination of all of them, just depending upon how preemie they are or how well their bodies are developing. But that's NRDS. Okay, moving on. Airway diameter is going to help determine the resistance. So besides how compliant lungs are, the airway resistance will influence how hard your body has to work to breathe. So as we talked about in Post-Sweet's law, the length of the tube, the viscosity of the tube, and the radius of the tube affect the resistance. Now the length of the tube and the changes in viscosity do play small roles in air resistance, but the radius of the airway plays the major role, again, just like in the cardiovascular system. So 90% of the airway resistance is typically in the trachea and the bronchi. So here you're talking about bronchioles, pulmonary arteries, and systemic arteries. Again, 90% of the resistance happens in the trachea and the bronchi, but the diameters don't typically change. The diameters don't change because they're supported by bone, and then all that blue stuff that we saw in the beginning was cartilage, which means that the diameter of them isn't changing drastically. It's not just smooth muscle. The cartilage keeps it a more constant diameter. So the only other factor would be mucus from allergies or from infections. If someone did have like allergies, allergies would obviously inhibit the radius, which could obviously decrease the flow, which would increase the resistance. Bronchioles don't typically affect the resistance unless something suddenly changes their diameter. Histamine is a powerful bronchioconstrictor that gets released from mast cells in response to allergies and tissue damage. Other bronchioconstrictors could include things like leukotrienes or acetylcholine from your parasympathetic nervous system. So bronchodilators would include elevated carbon dioxide levels and epinephrine, or they could also do that using their beta receptors. Okay, the rate and depth of breathing are going to help determine the efficiency of breathing. So the effectiveness of ventilation is going to be calculated by estimating the volume of air moving in and out of the lungs per minute. So this is going to be called your total pulmonary ventilation, or your minute volume, and it gets calculated by the ventilation rate times your tidal volume. So ventilation rate, something like you maybe breathe in 12 times per minute, and then tidal volume is how much air in per minute, and you get a TPV, your total pulmonary ventilation. That represents the physical movement of air into and out of the body. However, this is not a really good indicator of the fresh air that reaches the alveoli for exchange, because not all air that enters your respiratory system is actually going to reach the alveoli. Some of the air remains in the conducting tubes, so remains in your lungs, but it actually didn't make it to the epithelia just yet. So that's going to be what we would call dead space. An estimate of the anatomical dead space is most commonly about 150 milliliters. So that'd be your ventilation rate times your VT minus the dead space. So something like 12 breaths per minute times 500 minus 150 gives you 4,200. 4,200 milliliters per minute. That's an estimate. Okay, let's move to focusing on the movement. So if the movement of gases is impaired, an inadequate oxygen results in hypoxia. Typically, we'll see hypercapnia, which is elevated carbon dioxide levels. These are clinical signs that are going to lead to a diagnosis of a disease. So, by measuring all of your respiratory spirometer readings, you're going to be able to determine what parts of your respiratory system are working, where you may need some help, what you need to do to increase the efficiency of it. So, your body uses sensors in the to monitor carbon dioxide, pH, and oxygen levels in your arterial blood, as well as the CSF, right? The cerebrospinal fluid. So carbon dioxide and oxygen are going to diffuse along the partial pressure gradients from high to low and diffuse to equilibrium. Low alveolar partial pressure of oxygen is going to decrease oxygen uptake. So adequate oxygen, right? If you have enough, oxygen must reach the alveoli to ensure arterial blood gases are normal. So a decrease in the partial pressure of oxygen means less oxygen is available in the blood. So therefore, the inspired air has a lower partial pressure of oxygen. This is what would occur as altitude increases. In this case, hypoventilation caused by decreased compliance, increased airway compliance, or your CNS or your central nervous system could be depressed from like the use of alcohol or drug overdose, right? Basically, you stop breathing almost, or actually stop breathing. Diffusion problems can start to cause what we call hypoxia. Let's see. Perfect. Okay, so diffusion can cause what we call hypoxia, which is a problem with the transfer of gas to the capillaries, which will mean less oxygen is present. So the diffusion rate is affected by the surface area, concentration gradient, barrier permeability, and then the distance of diffusion. In healthy people, the concentration gradient is the primary factor affecting gas exchange, but in a diseased state, exchange with the blood can be impaired. So if you guys are looking at our bottom line here, right, this is a normal lung. The upside down tree is the bronchioles that's going to terminate at the alveoli. And then the blue to red on the bottom is your bloodline. So it's again the alveoli exchanging the oxygen and the CO2 into the blood, or out of the blood for that matter. This is normal. However, emphysema. Emphysema is going to destroy the elastic fibers of the lungs. When that happens, It gives high compliance and low elastic recoil. It also decreases the surface area, which reduces gas exchange and lowers the amount of oxygen that enters the blood. So again, destruction of the alveoli means there's a lot less surface area for gas exchange, which means that you're getting a lot less gas exchange, so it's hard to breathe. Next one is fibrolytic lung disease. This is where you have the thickening of the alveolar wall. You can see by the bolded line of the alveoli. So when you thicken the alveolar wall, it's going to change the diffusion barrier and makes it much more difficult for the gases to diffuse through. So diffusion through the scar tissue is slower, less effective, and therefore less oxygen enters into the bloodstream. So in this case, it's not showing you the red stripe in the blood because the red is oxygenated blood. So you don't have enough oxygenated blood in your capillaries. And then this last one over here is pulmonary edema. So if you have the accumulation of fluid in the alveoli or the IF, it's going to increase the diffusion distance and decrease the amount of oxygen in the blood. Pulmonary edema can be caused potentially by left side congenitive heart failure or mitral valve dysfunction. Edema can also occur from inflammation in the lungs. But again, basically, you have too much of a distance. It's too far for the gases to diffuse efficiently through, which means less to the body. This last one here, I don't think we talk about it specifically, but it is important because we live in the valley, so asthma is very common. So in asthma, you have an increased airway resistance, which decreases your alveolar ventilation. So you guys notice that the tree trunk, right, the upside down tree trunk is the bronchioles that I was talking about. The bronchiole is much, much smaller in diameter than your normal lung, which means there's much less air going through, which means it's a lot harder to get oxygenated blood down here, which is less effective. Oh, perfect. Next one. So PO2, partial pressure of oxygen, is determined by the ability of oxygen to bind to hemoglobin, because that's how most of your oxygen travels in your body. So the amount of oxygen that binds to hemoglobin is going to depend on two things. Number one is the partial pressure of oxygen in the blood around the red blood cells. And then number two, the number of hemoglobin binding sites available on those red blood cells. So the plasma partial pressure of oxygen is the primary factor that determines the percent saturation of hemoglobin with oxygen. I hope you guys would know oxygen saturation should be like 99 to 100. So they should basically be all used up. Partial pressure of oxygen available is affected by the composition of inspired air and the alveolar ventilation rate, as well as the efficiency of the gas exchange from the alveoli to the lungs. So you'll notice that when the partial pressure drops significantly, you only get about 50% saturation, which is obviously not good. So the total number of binding sites then is going to depend on the blood hemoglobin content, and any pathology that decreases the amount of hemoglobin or the number of red blood cells will negatively affect your body's oxygen carrying capacity. Okay, so oxygen binding is expressed as a percentage. So the percent saturation of hemoglobin is going to be the amount of oxygen bound to the hemoglobin at any given partial pressure of oxygen. So if all binding sites are occupied, the blood is 100% oxygenated. And if half are carrying oxygen, it'd be 50% saturated. Oxyhemoglobin saturation or dissociation curves are ways to help express the physical relationship between the partial pressure of oxygen and how much oxygen will actually bind to the hemoglobin. The shape of the curve reflects the properties of the hemoglobin molecule and its affinity for oxygen. So this is a typical curve that you would call an oxyhemoglobin binding curve. It's sigmoidal, right? It's S-shaped sigmoidal rather than linear, which tells us that the binding of oxygen to hemoglobin changes as oxygen is loaded and unloaded from the molecule. Hemoglobin demonstrates cooperative binding properties, meaning as one oxygen binds to the molecule, it causes a conformational or a shape change, and it makes it easier for the next one to bind. and so on and so forth. So the first one that was bound to the hemoglobin, the first oxygen molecule that became bound to the hemoglobin was the hardest one. The last oxygen that was bound to a hemoglobin molecule was the easiest one. During the unloading process, it's easier to remove the first oxygen, harder to remove the second, and then harder to remove the third, and so on and so forth. So it's opposites. So if you look at a normal dissociation curve at a normal partial pressure of oxygen, something like 100 millimeters of mercury, 98% of hemoglobin should be saturated. That 98 or above is natural, normal. The curve is relatively flat. So when the partial pressure of oxygen drops, we maintain high saturation percentages. So as long as the partial pressure of O2 stays above 60 millimeters of mercury, right? 60 millimeters of mercury, you're above 90%. We have 90% saturation or more. So hemoglobin saturation is going to decline more rapidly when you get into the steep portion of the curve, somewhere between 40 and 20 right there. Physiologically, the significance of that is that even in the venous system, when the partial pressure is about 40 millimeters of mercury, you still have about 75% saturation, which gives you enough of a reserve if metabolism increased or oxygen delivery temporarily stopped to your body. Okay, so there's a couple of different factors that are going to affect the oxygen hemoglobin binding capacity. Any factors that alter the conformation of the hemoglobin protein may affect its ability to bind to oxygen. So changes in the pH, temperature, partial pressure of CO2, and then a molecule that we'll call a 2,3-DPG. So the 2,3-DPG, you probably should have talked about in Bio 21A, which was a byproduct of aerobic metabolism. But we're going to just call it the 2,3-DPG for our purposes because it's long. So these three factors, or four factors, excuse me, are going to be what we talk about right now. So three of them go together hand in hand. So when you increase temperature, when you increase the partial pressure of CO2, and when you increase the 2,3-DPG, what happens is you're going to have a decrease in pH. So if you guys notice here, the outlier is the pH. So again, changes in, not changes, an increase specifically in temperature, partial pressure of CO2, and an increase in the 2,3-DPG would cause the pH to go down. So all three of these, 1, 2, and 3 go up, pH goes down. So that would shift the curve to the right? Shift the curve to the right in the dissociation curve, meaning that it's easier to bind. So, and then vice versa. So this would occur, actually, let's go with it. So shift the curve to the right. More oxygen is released to the tissues, which is a good thing because oxygen released to the tissues creates energy. This would be during times of exercise or high altitude. Maybe you're anemic and your body perceives you needing more. Diabetes, hypoventilation, those are all shifting the curve to the right. Now, vice versa, if you decrease temperature, decrease partial pressure of CO2, decrease the 2,3-DPG, but increase the pH, what's going to happen is you're going to shift the curve to the left. When you shift the curve to the left and move it all that way, what happens is there is less oxygen that gets released to the tissues, more just being bound. So this occurs in like hypothermia, hyperventilation, vomiting, dehydration, alkali consumption. So they're antagonistic. Those are very important for you guys to know. Make sure you guys study these. The last thing that we're going to talk about today is the way that we carry carbon dioxide in our body. Okay, couple ways. So carbon dioxide removal from the cells is very important because it's produced through cellular respiration, but it is more soluble in body fluids than oxygen. So it can become toxic if it builds up in your body without being released. So more carbon dioxide is produced than can be dissolved in your blood. So your red blood cells have to convert much of it into what we call bicarbonate. Bicarbonate is very, very helpful for your body. It's a buffer, and you can use it in all different areas or store it for later. So elevated carbon dioxide or hypercapnia can lead to acidosis. Acidosis then can interfere with hydrogen bonding, could denature proteins, it could depress your central nervous system and cause confusion, coma, death. Hydrogen bonding is done between your nucleotide bases of your DNA, so that could damage your DNA. Obviously, pairing, which is very bad because then you'll have mispairs potentially, or denature proteins, which are all enzymes or catalysts, and that's also very bad. So carbon dioxide gets converted into bicarb, and that's going to serve as the major way to transport CO2 in the lungs. And then bicarbonate can act as a buffer for your metabolic acids to help stabilize the body's pH. So, three ways, right, that your carbon dioxide gets transported. One is as bicarbonate, and then two, you could move it through, diffuse it directly into the plasma, and then three is on hemoglobin. We're going to talk about converting it at the tissues. So, there's two different um, graphs that we're going to go through, or mechanisms that we'll talk about here. It's called a chloride shift. So the chloride shift is talking about transportation of carbon dioxide in your body, or out of your body for that matter. And you're going to have two different chloride shifts. One of them is going to be at the tissues. The other one is going to be at the lungs. So the chloride shift at the tissues goes like this. Number one is CO2 diffuses out of the cells and into the systemic capillaries. So out of the cells and then into the systemic capillaries, where we'll call that the venous blood. Number two, 7% of your carbon dioxide is going to be dissolved directly into the blood plasma, right? 7%, not a whole lot, but some of it can go directly into the plasma, directly into the blood. 23% of it is going to bind to hemoglobin, and it's going to be called carbaminohemoglobin. So you've put the hemoglobin and the carbon dioxide together. That's going to form an HbCO2. HbCO2 is the carbaminohemoglobin. That's the 23%. The formation of the HbCO2 is aided by the presence of hydrogen ions. When that happens, it's going to reduce the hemoglobin's affinity for oxygen. When you reduce the affinity for oxygen, it's going to kick oxygen out of the cells, right? So you reduce the affinity for oxygen. Now it's going to start kicking oxygen out of the cells. That would be the HbO2 plus the hydrogen ions right here. And then you're going to start kicking stuff out of the cells. So the hydrogen ions are produced during the formation of the bicarbonate. Bicarbonate is this, right? So it's the HCO3 minus. That would be the bicarb in the red blood cells. 70% of the CO2 is going to mix with water and enzymatically convert by what we call carbonic anhydrase, or Ca. So 70% of it, right, goes this way. Then you can enzymatically convert with, carbon dioxide plus water, carbonic acid would make your H2CO3. So at this point, it's going to, again, enzymatically convert by carbonic anhydrase to carbonic acid, and then it's going to dissociate to bicarbonate and hydrogen ions. The bicarbonate exits the red blood cells via an antiport here. Antiport, just again, one goes in, one gets out, anti, in exchange for the chloride. Now you have the bicarbonate going out into the blood plasma and the chloride going in, which is why this is called the chloride shift at the tissues, because the chloride goes in. The chloride has to go in to balance the charge in the red blood cells when the bicarbonate buffers the metabolic acids into the plasma. That's the first shift. Second shift is down here. So the second shift is at the lungs. This is when the venous blood reaches the lungs. The reverse reaction is going to take place that occurred in the systemic capillaries. So first is the bicarbonate is going to have to enter the red blood cell. So bicarbonate goes into the red blood cell as the chloride exits. So chloride goes out, bicarb goes in. This is going to be called the chloride shift at the lungs, right? You can see transport to the lungs. So this is chloride shift at the tissues. This is chloride shift at the lungs. So bicarb goes in, chloride goes out. Now your hydrogen ions are going to release from the hemoglobin, and the free hydrogen is now going to link up with the bicarbonate to help form the carbonic acid, right? To help form the carbonic acid, you're still using Ca. Ca is a very good enzyme. Carbonic anhydrase is going to convert the carbonic acid into the carbon dioxide and water. Right now you've got the carbon dioxide and water. Now the carbon dioxide is going to be free to diffuse out of the red blood cells into the alveoli. Since hydrogen ions are reduced in the red blood cells, the affinity of the hemoglobin and oxygen changes. Now that oxygen is again attracted to hemoglobin, it leaves the alveoli, enters the pulmonary capillaries, and now binds to the hemoglobin, which forms oxyhemoglobin. That's perfect. Now you can transport it to anywhere else in your body and utilize it for um, cellular respiration. So again, one more time, here's the chloride shift at the tissues and then the chloride shift at the lungs. If you guys have any questions about this, please let me know and I'd be happy to help you. Good luck with it, and I look forward to answering any questions.